Inflammatory myopathies. Part 3. Inclusion body myositis. Inclusion body myositis is an inflammatory muscle disease characterized by slowly progressive weakness and wasting of both distal and proximal muscles, most apparent in the muscles of the arms and legs. It is the most common idiopathic inflammatory myopathy occurring in patients over the age of 50 years. It accounts for about 30% of all inflammatory myopathies. The prevalence has been estimated to be around 5 to 10 per million, but varies in different ethnic groups. It is more common in males than females. Male to female ratio is 3 to 1. There are two types: sporadic inclusion body myositis, SIBM, which is more common; hereditary inclusion body myopathy, HIBM. The common pathological findings of the inclusion body myopathies are vacuous and filamentous inclusions. Etiology. The exact etiology is idiopathic. However, though it is likely that the disorder results from the interaction of a number of factors, both genetic and environmental. There is an association between IBM and other autoimmune disorders such as SLE. It is strongly associated with the MHC antigens such as HLA-DR3, DR52, and B8. Hereditary inclusion body myopathies. Hereditary group of disorders are characterized by: most are of late onset, but congenital and childhood forms have been described. Muscle reveals remain vacuous with accumulation of the same proteins as in sporadic inclusion body myositis, but no inflammatory infiltrate, so it is called inclusion body myopathies. Several genetic defects have been identified, such as mutations in the GNE gene that cause inclusion body myopathy 2, GNE myopathy, which is inherited in an autosomal recessive pattern. Clinical features. The distribution of weakness in SIBM is variable and follows a slowly progressive course. Both proximal and distal muscles are usually affected, and unlike polymyositis and dermatomyositis, asymmetry is common. Early involvement of the knee extensors, in particular quadriceps, ankle dorsiflexors, and wrist and finger flexors, is characteristic of sporadic inclusion body myositis. Dysphagia occurs in 40 to 66% of patients and is a progressive condition. Myalgias and cramping are relatively uncommon. Laboratory studies. In most cases of SIBM, serum CK level which is non-specific marker of muscle damage, is normal or elevated to a mild to moderate degree, up to 10 times the upper normal limit. Elevation of serum CK level greater than 12 times normal may occur but is rare. Myositis associated autoantibodies are usually not found. Investigations. MRI can demonstrate areas of muscle inflammation, edema with active myositis, fibrosis, and calcification. MRI findings involve selective atrophy of the quadriceps and forearm flexors. MRI is non-specific and may not distinguish the changes of inflammatory myopathy from those that occur in rhabdomyolysis, muscular dystrophy, or metabolic myopathy. Electromyography EMG shows myopathic changes, which is irritable myopathy with superimposed peripheral neuropathy. EMG and MRI are helpful in localizing and selecting an appropriate muscle group for a muscle biopsy and monitoring therapy. Microscopic features. Microscopic features. This photo shows small angulated and round myofibers that may be scattered through the biopsy or in clusters. This photo shows endomysial mononuclear cell inflammatory infiltrate with invasion of non-necrotic myofibers. H&E reveals vacuoles surrounded by basophilic granules. Invasion of inflammatory cells in a non-necrotic muscle fiber. These two photos show variation in myofiber sizes, with small angulated myofibers, hypertrophied myofibers, splitting, and increase in internal nuclei. Normal muscle can have up to 3% of myofibers having internal nuclei. CD8-MHC1 complex is a characteristic finding in the immunopathogenesis of inclusion body myositis and polymyositis. Immunohistochemistry shows cytotoxic CD8 positive T cells invading a non-necrotic muscle fiber. Immunofluorescence shows upregulation of MHC1 with increased expression. Upregulation of MHC1 with increased expression both at the sarcolemma and in the cytoplasm of several fibers. Ragged red fibers and numerous fibers with COX deficiency stained by COX-SDH double staining due to deficiency of mitochondria. Many inclusions in vacuolated fibers are immunoreactive with an antibody to P62. Immunofluorescence of P62 localizes inclusions in vacuolated muscle fibers, which has green color. These three photos show rimmed and inclusion with gomory trichrome. The vacuoles may be immunoreactive for beta-amyloid, beta-amyloid precursor protein, and ubiquitin. Inclusion body myositis are stained with Congo red and viewed with polarized light. Ubiquitin immunostudy reveals ubiquitin positive inclusions within the vacuoles. There are several congophilic inclusions which show birefringence. See the arrows. Electron microscopy shows a cytoplasmic inclusion of 15 to 21 nanometer tubular filaments surrounded by myelin-like wares. Electron microscope can show an intranuclear inclusion of tubular filaments, myelinoid bodies, and abnormal filamentous inclusions. Differential diagnosis. Vacuosis can occur in several conditions, and they are of different types. The situation where they are most common are inclusion body myositis, distal myopathies, glycogenosis, and periodic paralysis. Although absence of vacuosis in a sample does not exclude these diagnoses. Polymyositis. IBM is often initially misdiagnosed as polymyositis. Polymyositis shows progressive symmetric proximal limb muscle weakness with insidious onset, myalgia, and tenderness. Dysphagia is present in 1/3 of patients. It does not show rimmed vacuoles or ragged red areas by gomory trichrome stain. It does not show intracellular amyloid deposits, that is Congo red negative. It does not show P62 or beta amyloid immunoreactivity. Electron microscopy does not show tubular filaments in the sarcoplasm or structurally abnormal mitochondria. It is responsive to immunosuppressive therapy in the majority of the cases. Isolated granulomatous myositis. Granulomatous myositis is a rare condition usually seen as manifestation of sarcoidosis in 10%, but isolated granulomatous myositis may occur without systemic manifestations. Isolated granulomatous myositis may present as chronic proximal muscle weakness and could have a predominantly distal distribution in many cases and may mimic inclusion body myositis. Granulomatous myositis is not a CD8 positive MHC1 complex lesion, but it is macrophage helper T cell clustering and HLA-CD4 complex lesion. Granulomatoous myositis affects adults and elderly men and women, similar to inclusion body myositis. It shows well-demarcated non-caseating epithelioid granulomas in the muscle biopsy. It does not show intracellular amyloid deposits, immune reactivity to P62 or beta amyloid tubulofilaments in the sarcoplasm or structurally abnormal mitochondria. Steroid treatment is usually effective in isolated granulomatous myositis, whereas inclusion body myositis is refractory. These three photos show well-demarcated non-caseating epithelioid granulomas, which may be found in the endomysium or perimysium, along with mononuclear inflammatory cell infiltration, obliterating normal muscle architecture. There are patchy non-specific myopathic features with fiber size variability, internalized nuclei in muscle fibers, muscle fiber necrosis and regeneration, fat infiltration, and increased connective tissue. Treatment and prognosis. No definitive treatment has been proven effective for SIBM. It is refractory to immunosuppressive and immunomodulatory therapy, so it is called steroid-resistant myositis. The patients need supportive and rehabilitative care. Prognosis is that of slow progression over 5 to 20 years to disability. Conclusion. Inclusion body myopathies are CD8 positive MHC1 complex lesions. Inclusion body myopathies eventually evolve into a syndrome of diffuse progressive, asymmetric proximal and distal weakness that is generally refractory to immunosuppressive treatment. The common pathological findings of the inclusion body myopathies are vacuoles and filamentous inclusions. The CD8 positive MHC1 complex, that is MHC1 along with the CD8 positive cells, is specific for the inflammation in polymyositis and inclusion body myositis, and needs to be incorporated into the histological evaluation in an effort to rule out the secondary inflammation seen in various dystrophies or toxic myopathies, that is non-immune myopathy. Thank you.